and epilepsy and heart. Over to Dr. Prakash.
Thank you, Dr. Mahesh sir. And first of all, I should thank Dr. Palani for making me give a talk, which I thought made me wonder what is this topic first, because I really didn't know what was there in that. And I said, what is there epilepsy? And he told me, no, you read up, you'll be interesting. Really fascinating and interesting. And after he gave me this topic, epilepsy and the heart, I actually spoke to a couple of intensivists and emergency physicians. And I said, have you seen any interaction between epilepsy and the heart? They said, no, sir, we are not aware of that. Nothing is possible. Then I told one of these emergency care guys, see, these things can precipitate VT. And I showed him an ECG. He said, we always thought that was because of the epileptic activity, the monitor is showing all this activity. So that is the level of ignorance on this topic. And with that introduction, let me go into the history of this. In fact, the first description of this particular problem was actually given in 2006 in Lancet. Russell first described it and said, during epilepsy of a patient, he held one hand and found out that there was no pulse. This is what was the original description. And this has come a long way since then. And today what we are seeing is a much different scenario. And in the 2021 analysis, they found out when they looked at 10,241 patients with epilepsy, and they matched it with controls, and there was an increased risk of cardiovascular events. Just about hazard ratio was 1.58, which is quite a lot. But they compared different drugs and found out it is not there. And the conclusion that they gave was very, very important. I'm giving this as an introductory slide to give you an appraisal of what I'm going to talk. They say that cardiovascular risk management is important in people with epilepsy. Now, point one, I never knew something like this existed. And I have never seen a neurologist refer a case of epilepsy to me for cardiovascular risk management. I don't know whether they do. I think you people have to educate me after that. The same study, if you look at the hazard ratio of 1.58 between the control group and this, the statistical significance was 0.001. It's extremely significant. They also differentiate between the anti-epileptic drugs, the enzyme and the non-enzyme inducing drugs. Now, the difference between these two drugs is that the enzyme inducing drugs seem to be having an abnormal lipid profile by acting through the cytochrome P450 system. But they did not find, but there are other data which I will show over the next few minutes. Now, historically, these data has always been there. And in the Amsterdam arrest resuscitation study, they found out that the corrected hazard ratio for epilepsy and for getting a cardiac arrest was 2.9. Now, compare this with diabetes, which is actually 1.2. So it seems to be more important risk factor and more commonly associated than even diabetes. But obviously, heart failure and ischemic heart disease are much more. But if you look at it, I think we should understand you're dealing with a much more cardiac patient who's going to die from cardiac causes than epilepsy itself. Now, the Oregon Sudden Unexpected study put some question marks on this. Now, what they said, there is no relationship between seizure and sudden cardiac activity. But they found out something more interesting. They said that the worst rate of survival from sudden cardiac arrest was found in epilepsy. Now, this made people think and wonder what exactly is happening. Is it part of epilepsy? Is it not part of epilepsy? And what do the anti-epileptic drugs do? Parni has been talking about the sodium channel blockers. They found out that if you take carbamazepine and gabapentin, the sudden cardiac death incidence is more by 3.2 and 5.7 fold. We keep giving gabapentin left, right, middle, and center for most of the patients with neuropathy. We never think about this. What about cardiac patients? There is no specific data on that. And elevated levels of lipid, they were found in some of the epileptic medicines. Carbamazepine specifically increased the triglyceride levels. Valproate actually increased HSCRP. We talk quite a lot about this because we find that these patients can be more prone for problems with inflammatory heart disease. Long-term efficacy or the long-term effects of anti-epileptic drugs, you see, as the duration of the anti-epileptic drug increases, there is an increased carotid intimomedial thickness. That is a surrogate marker for atherosclerosis. So there seems to be an increasing atherosclerosis independent of the aging and the time factor involved in these patients. So this leaves us with a lot of unanswered questions. Why is there an increased mortality? Why do these patients fare badly after a sudden cardiac arrest? Is it a direct effect or not? And what is the role of anti-epileptic drugs? Now, this brought us to this question, the word called sudden unexplained death in epilepsy. Now, very few people seem to be knowing about it, including me, till I started preparing for this lecture. Now, basically, the International League Against Epilepsy has described it as a sudden, unexpected death in a person with epilepsy, with or without evidence of seizure preceding the death. That's important. It need not be at the time of seizure, with or without evidence of seizure preceding the death, in which there is no other cause for cause for death like other disease, injury, or drowning that could cause death. So basically, it's a sudden, unexpected death in epileptic patient with or without evidence of seizure preceding that episode. Sudden unexpected death seems to be 20-fold greater than the general population in this group of patients with epilepsy. Now, this data from Stecker et al. Had something again showing that there was about 4.4% of the entire deaths sudden deaths in 2018. They found that 4.4% had epilepsy, which actually translated to 44 deaths per day. It's quite a lot. And the 4.5-fold increase in sudden unexplained death in pregnancy is actually more than that of what we said previously in this slide, weighing is 2024. So actually the number seems to be much more, and we just don't seem to be calculating the problems. So what are the risk factors? Who are going to develop it? Basically, poor compliance with anti-epileptic drugs, younger age group, early onset of seizures, prevalence of GTCS, male sex, and being in bed at the time of death. Now, being in bed at the time of death, I think everybody has to sleep. I don't know about that, but basically this is probably related to the prone position and choking themselves to death. But what alarmed me most was the last line, which said the typical age of SUDEP is 20 to 40 years. We generally tend to ignore those patients, thinking about them. You treat the epilepsy, control the epilepsy, probably they are fine. But those patients, especially the men, are more prone for death. Now look at the timeline of what happens to the heart in these patients. You will see that in the interictal phase, there could be arrhythmias, myocardial ischemia, and heart failure. In the pre-ictal phase, the heart rate starts rising. And in the ictal phase, two things could happen. The respiration could fall. There could be a hypoxia-induced bradycardia, AV block, and asystole have been documented. Heart rate elevations is the most common thing. Nearly 85% of the patients have increase in heart rate, sometimes ventricular tachycardia. I'll show you some of those. Because of persistent tachycardia, there could be what is called a stress-induced Takotsubo syndrome, transient myocardial ischemia. But the highest risk seem to be actually in the post-ictal phase, wherein these patients could go in for a post-ictal VT, VF, or asystole. So all these things could happen, and we don't even think about doing anything for these patients. That is the big surprise that keeps happening. So this brought to the concept of epileptic heart. This epileptic heart concept basically came in because of the original autopsy studies, which showed that patients with epilepsy had increased atherosclerosis, the hypertrophy of chambers were more, cardiomegaly was more common, atrial enlargement was common, and they found myofibrillar degeneration. And in post-epileptic phase, the cardiac troponin I was elevated. Now, troponin I is very specific for the heart. Troponin T can come from the muscle, but troponin I is very specific for the heart, and that was elevated in 25%. 1 in 4 persons have a myocardial damage post-epilepsy. And the Stockholm heart study showed that epileptic patients, compared to the general population, had 4.8 times more incidence of myocardial infarction. Everything seems to be pointing to a very close knit between these two problems. And this chronic cardiac epilepsy effects seem to be related to the repeated hypoxemia during the seizure and myocardial ischemia that happens. And catecholamines are released during these episodes of epilepsy. These two seem to be producing accelerated atherosclerosis. They seem to be showing increased interstitial fibrosis, and ECG changes are also documented. So the epileptic heart has been described as a heart and coronary vasculature damaged by chronic epilepsy as a result of repeated surges in catecholamine and hypoxemia, leading to electrical and mechanical dysfunction. Now, this is how the epileptic heart has been described. Now, this is the ECG I was talking to you about. Now, this patient during an EEG with an ECG monitored had an epileptic activity, and during that he required a shock, cardiac shock, because he developed ventricular tachycardia. Now, this has also been documented in patients who had implantable cardioverter defibrillators for heart failure. They found a 3.5-fold increased risk of ventricular arrhythmias in patients who are known to have epilepsy. So it just seems to be coming everywhere that there is a cardiac issue associated with epilepsy, and several ECG changes have been documented. There has been a relatively increase in cardiac rate, rhythm, repolarization abnormalities, ST changes, and this has been found in several cases, like I said, bradycardia and asystole. Commonest finding in 82% was ictal sinus tachycardia during the seizure, and heart rates above 150 have also been documented. And there is a reduced heart rate variability in these patients if you do it in the interictal phase. Now, what is the reduced heart rate variability? Basically, it means that the vagal activity is less, and those persons have more sympathetic activity and more myocardial damage. Ventricular late potentials, which are marker for sudden cardiac death, have been found to be higher, and T-wave alternance is something very specific noted in the interictal phase of chronic epilepsy. Now, what is this T-wave alternates? The most common method they use is what is called the MMA method or the modified moving method. What they do is they look at alternate beats, the odd beats, the A beats and the B beats. They are averaged, and between them, they found out whether there is a change in the T-wave amplitude. I will show you some examples of what happens here. And here, it is more specific at a heart rate less than 110. Spectral analysis during stress test can also be used. Now look at these examples. Look at this one on top here. You will see that this T-wave and the second T-wave all are different. Now these patients have, again, differential T-waves here. Here, these T-waves are all quite different. Look at this, much more clear in panel C. Top one, second one, top one, second one. And this actually degenerates to ventricular tachycardia and ventricular fibrillation. The last one is very, very clear, alteration and patient degenerating to ventricular tachycardia. So this is a very well-known phenomenon. It can be used to detect those patients who are going to be prone for sudden cardiac death. The heart-brain interaction is very interesting. I think I'm sure a lot of the neurologists know very well about this, that there is a connection between the sympathetic, parasympathetic flow. Everything has a central connection, and the adrenal gland and the entire heart rate, contractility, conduction, repolarization, and blood pressure are all controlled basically from the brain. We are just the end organs in the heart. And what happens to these sudden cardiac death patients over time? You will see that the more than 40-year-olds, the number of deaths seems to be very, very high. The sudden death in epilepsy also seems to be very high. Now, when you start looking at these patients, as age advances, there is also a natural progression of disease. Now, outside that, when you start giving anti-epileptic drugs, there is a reduction in seizure, but there is an increase in the lipids, especially with the enzyme inducers. And there is an increased risk of sudden cardiac death, especially in the sodium blockers. So what can you do? If you do an autonomic modulation for these patients, there could be an increase in parasympathetic activity, which could be protective, reduction in the sympathetic activity, reduction in seizure, and increased cardiac electrical stability. So these are different postulations. And with that, they tried looking at what happens to vagal nerve stimulation. Now, vagal nerve stimulation is something like a pacemaker. Now, this central X-ray shows two things. The one on the left side of the chest is the ICD. ICD has two wires that comes one to the atrium and to the ventricle. And you see the one on the VNS, sorry, that is connected to the vagus. So you can have both in a patient, and this will repeatedly keep stimulating the vagus and induce vagal activity. The problem with these implantable devices, especially the vagal stimulation devices, are that there is an 8.6% complication rate in the implant site. Now, there could also be a hoarse voice, throat pain, coughing, and other complications. But when you start using these drugs, the T-wave alternance significantly comes down. Now, this is a patient look at here, the A beat and the B beat that I showed you. There is a T-wave alternance which has disappeared after the post-vagal nerve stimulation. Now, what about the long-term effects of vagal nerve stimulation? According to cardiac death, the sudden cardiac death with pregnancy, with epilepsy, seems to be coming down over years, clearly showing that vagal stimulation has a role in reducing at least the sudden death in pregnancy, in epilepsy. So what happens to the void in the management of epilepsy? I think the problem is there is no routine cardiac assessment that is done in epilepsy. Cardiac comorbidities, because there is an increased atherosclerosis, like I showed you, is not addressed. And at least take a 12-lead ECG, ambulatory ECG, Holter monitoring can be useful. And in a Holter, you can also look at the T-wave alternates. So these are markers to know which patient is going to die, and better to have the patient than to lose the patient. Now, the problem doesn't come with seizures in the heart alone. There is a reverse action also. Heart disease also produces some effects. Now, in congenital heart disease patients, there is an increased incidence of epilepsy that has been known. And patients without intellectual disability, the hazard ratio is 2.3. When prematurity was excluded, it was 3.3. Now, basically, there is an increased risk of stroke in congenital heart disease because of the polycythemia that happens. And those patients seem to be having higher incidence of epilepsy, whether it is related to the stroke or directly, that also is not clear. But there is some association that has been mentioned. Now, with that, they try to look at why does stroke and heart disease keep happening. That is when the common soil hypothesis has been proposed, wherein there is an age-accelerated atherosclerosis and an age-accelerated cognitive or behavioral decline. Now, both these, when they studied together, they found they had high carotid intermedial thickness, homocysteine levels, lipid, weight gain, obesity, insulin resistance, higher inflammation. Everything was found to be at a higher state. And you look at late onset epilepsy, it is more common in elderly, more common in hypertensive patients, more common in diabetics, and more common in obese. So basically, late onset epilepsy seems to be behaving exactly like atherosclerosis. So there is some common soil between the two, needs more interaction and more studies. And another interesting point about late onset epilepsy is there is an increased incidence of heart failure. Now, this I'm very interested and passionate about heart failure because till the diabetic studies with the SGLT2 inhibitors came, we did not talk much about heart failure and diabetes. Now everybody talks only about heart failure, and that has become a bigger problem than atherosclerosis. Late onset epilepsy may also come into this in future at this point. And the association is actually stronger in younger patients with epilepsy and in men. So you have to watch out for heart failure. Probably you have to do an ECG and an echocardiogram. Look at especially heart failure with preserved ejection fraction or reduced ejection fraction. This has enormous importance, stresses the enormous importance of extracerebral comorbidities in epilepsy patients. Finally, ladies and gentlemen, to conclude, chronic epilepsy damages the integrity of the heart and its vasculature because of the persistent sympathetic activity and persistent hypoxia that damages the heart and produces what we call as the epileptic heart. The SUDEP, or the sudden unexplained death in epilepsy, has a 20-fold increase and compared to the general population, and it has an increase of at least 3-fold compared to the general population in sudden cardiac death. T-wave alternates can detect arrhythmia risk to improve diagnosis, and maybe it can guide therapy also because it has been found more often in resistant epilepsies. Vagal nerve stimulation probably can afford a dual protection by reducing the seizures and suppressing the cardiac electrical instability. And importantly, I think as cardiologists and neurologists, whenever we see somebody with epilepsy, I think we should not only look at epilepsy, look at the other risk factors that are there for epilepsy. And I think we should remove the mask of epilepsy and look below the patient and look at the other factors that are hidden, and we'll come up with more answers. Thank you very much for the patient listening.
Thank you, sir, for your eye-opening lecture. Carbamazepine and gabapentin causing sudden death in epilepsy, increasing drop eye by 25% in epilepsy, increasing heart failure in late onset epilepsy patient, and an increasing lipid profile by enzyme induces all the new points to remember. Thank you once again. Thank you very much, sir. Now, I invite